Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
This is Lindsay Smith-Rogers. Opioid use disorder treatment for pregnant people is a standard of care, yet many aren't able to access it due to stigma and a lack of knowledge about this life-saving treatment. The situation is even worse for pregnant people who find themselves in the carceral system. Dr. Carolyn Suffren, an OBGYN at Johns Hopkins, and Camille Kramer, a doctoral student and Bloomberg American Health Initiative fellow, join us today to talk about their new study looking at the availability of this treatment for incarcerated pregnant women in jails and prisons across the U.S. Let's listen. Dr. Carolyn Suffren and Camille Kramer, thank you so much for being on Public Health on Call. Today, we're going to talk about opioid use disorder treatment in pregnancy for people who are incarcerated. We've talked about opioid use disorder treatment in pregnancy before on this podcast, but just to give everyone a little bit of a refresher, Carolyn, could you walk us through what this entails?
Sure. So before even what the treatment entails for this situation, I want to highlight that opioid use disorder is a major contributor to maternal mortality in the United States. So we're not only talking about a healthcare condition that needs treatment. Of course, we are talking about that. But the reason we are talking about it is because people are dying. And we have seen an increase in the number of pregnancies that are affected by opioids and an increase in the number of opioid-related deaths that occur within pregnancy or up to 1 year postpartum. The standard of care treatment for pregnant and postpartum individuals with opioid use disorder is that they should be on medication treatment, medications for opioid use disorder with methadone or buprenorphine, and they should not go through withdrawal. The reason why that is the standard of care is because withdrawal in pregnancy is associated with maternal and fetal risks. And the biggest risk, especially the maternal risk, is that people relapse and overdose and die. Treatment reduces that risk. If you want to have a healthy baby, you need a healthy mom who is alive.
So this is the standard treatment for pregnant individuals who are experiencing opioid use disorder. Your study looks specifically at these individuals who are in a prison system, who've been incarcerated. So Camille, could you tell us a little bit about the study and what you did?
Yes. So our prior study called PIPS, the Pregnancy and Prison Statistics Study, found that about 8,000 pregnant people with opioid use disorder pass through jails annually. So we really wanted to get an understanding of whether or not evidence-based medication treatment was available to them in jail. And if it was, what was the experience of that care? So we conducted a mixed method study that involved a national survey of jails to find out the landscape of treatment availability. And then we also interviewed opioid treatment providers in the community, jail medical and custody leaders, and pregnant people with opioid use disorder to understand their perspectives.
And Camille, go ahead and tell us, what are some of the things that you found?
Yeah, so our survey, which is the largest survey of jails ever conducted, found that availability is variable. Only about 60% of jails continue treatment. So if someone was on it prior to being incarcerated, they would continue that treatment. Only 32% will initiate care. So that is a very low number. And then what is very alarming is that 76% of jails will stop treatment once the pregnancy ends, which dramatically increases the risk of overdose death after release.
And so, Carolyn, I want to ask you, what does access to opioid use disorder treatment behind bars look like in general?
It's very hard to answer anything about prisons and jails in general because there is so much variability, which is a big part of the story. There are no mandatory standards of healthcare for incarcerated individuals, although they do have a constitutional right to healthcare based in the Eighth Amendment that prohibits cruel and unusual punishment. There are also some states that have laws that require institutions of incarceration, sometimes it's jails, sometimes it's prisons, sometimes it's both, to provide access to medications for opioid use disorder. Maryland is one of those states that requires it for jails. But what does it look like in pregnancy? Well, what we've learned from this study is that Indeed, it is highly variable. And Camille highlighted some of the statistics about what the availability looks like. And if you consider what the standard of care is, which is that pregnant individuals with opioid use disorder coming into jails should be allowed to continue pre-existing medications they were on and to initiate medication treatment with either methadone or buprenorphine, that was only 18%. Only 18% of the jails we surveyed, and we sent the survey out to 3,000 jails, are achieving that standard of care. But even when that is available, what does it look like on the ground? That's what our qualitative research explored. We interviewed pregnant and postpartum individuals who had the experience of being incarcerated while pregnant with opioid use disorder. We interviewed 32 of them in various states. And we found that some of them were at jails that forced them to go through withdrawal, that did not provide access to treatment. Many received either no information about treatment and the risks of withdrawal, the risks and benefits of treatment, or they received completely inaccurate information about medication treatment and pregnancy. Many women who were at jails that did provide, at least on paper, methadone or buprenorphine, many women described delayed care where they still had to go through withdrawal for a few days before they actually got into treatment, or they were humiliated throughout and stigmatized and made to feel that they were unfit mothers, which then had impacts on their willingness to continue treatment, which again, treatment is life-saving in pregnancy. Women also described difficulties accessing their medication on time in jail or getting appropriate dosages, getting appropriate access to prenatal care. And women also described intense fear and stress about what would happen in terms of the involvement of the child welfare system in their pregnancies and after delivery.
So I want to ask, to put this research in a little bit of a larger context from kind of two viewpoints. And the first is overall the treatment of women who are pregnant and needing prenatal care in the incarceration system. And then secondly, I want to ask a little bit about just in general, people who need opioid use disorder treatment in this system as well. Can you contextualize this research a little bit? Let's start first of all with overall how pregnant women are receiving care. Let's start with you, Carolyn.
It's highly variable. There are some jails where a woman will come into the jail or a person with the capacity to be pregnant. They will be screened at intake. Maybe they will be offered a pregnancy test, but maybe they will not, and they won't even know if they're pregnant. If they are pregnant, it's highly variable whether they will receive options counseling as to what they can do with their pregnancy, if they can access abortion, what will happen if they continue their pregnancy. And then if they continue their pregnancy, prenatal care, highly variable. There are some jails that do provide access to a reasonable measure of quality prenatal care by a qualified provider, either an OBGYN, family physician, nurse practitioner, midwife, physician assistant who with training. But there are many, many jails that have no specialized care, no system set up. And so when a pregnant individual comes into their jail, they can't really offer them even the basic prenatal care that they need. So it's highly variable, that prenatal care. And then if you think about the experience, they're in this environment that is isolating, that is full of uncertainties. What will happen if I go into labor while I'm in jail? In some jails, their complaints of labor are disregarded. In others, it's not. So it's really highly variable. But across the board, what our participants in the study described was intense fear and uncertainty, the conditions of incarceration, the environment, the dirty environment, the lack of access to care, and knowing what was going to happen with their care.
And Camille, maybe you could provide a bit of context for us about how any individual might access this kind of treatment in the incarceration system.
Yeah, sure. So one thing that we heard in our interviews with jail staff is that at least jails are providing this treatment to pregnant folks, which we see that is not consistent. In our survey, we also asked questions about whether or not they provided medication treatment to non-pregnant people, and those numbers were significantly lower. Only 13% of all of the jails we surveyed both initiated and continued treatment, and 11% only continued MOUD. So many times jails prioritize the fetus, which was another theme of our interview. So when it comes to non-pregnant people, care is very limited, and most folks are forced to go through withdrawal.
Carolyn?
In terms of how delivering this care might look, if they are providing it, again, it's highly variable. Some jails have the capacity to provide methadone or buprenorphine on site at their jail. And recently, with lifting of restrictions on prescribing of buprenorphine, the ability to prescribe buprenorphine in a jail is vastly increased. And it's hard to imagine a reason why a jail should not provide buprenorphine and should not just add it to their formulary because there are no longer restrictions. Methadone, there are more restrictions. And so what that might look like for a pregnant individual, perhaps, or even a non-pregnant individual, if a jail can't provide methadone on site, if they're not a certified opioid treatment provider, they might have to be transported off-site every day for their daily methadone dose. And if you're pregnant, that's especially a concern because the default is to shackle incarcerated patients when they're taken off-site. Shackling at any point, poses health risks. There are security justifications given, but in pregnancy, they should not be used. Those health risks are exacerbated. And 41 states and the District of Columbia and the federal government have laws prohibiting shackling in labor and in pregnancy. And so those have to be applied when people are taken off site, but they're often violated.
I wanted to also ask, why aren't these things being provided? We have patchworky prenatal care. We have a standard of care that includes opioid use disorder treatment. We know it's not readily available to a huge majority of people that are dealing with this situation. Why is that? So, Camille, do you want to speak to that?
Yeah, I think there are a number of reasons. The first is probably lack of knowledge and stigma. So many people don't know that the evidence-based treatment for opioid use is to be on medications. And then a lot of people have feelings about being on that type of medication when you are pregnant. So I think stigma and judgment is a huge barrier when it comes to providing this treatment. Another thing we heard, like Carolyn mentioned, the shackling, is there are logistical challenges for providing treatment, whether they need to bring a physician on site or transport patients off site. Some jails, especially rural jails, are in treatment deserts. So the nearest OTP may be very far away. And if this person needs dosing every day, it's very difficult to do. But I also just think that a lot of people have feelings about using opioids to treat an opioid use disorder, unfortunately.
And is that because of a lack of understanding about how these things work? Could you talk a little bit about that?
Yeah, I think addiction treatment in this country is highly stigmatized in general. And I think a lot of people who are not familiar with it also don't understand that these medications help with cravings, they help with withdrawal symptoms, and they make a person who is using opioids get to that normal state.
So let's talk big picture here. You've done this research, you know the results, they're not great. What do you hope to see next, Carolyn?
We hope to see jails changing their culture and changing their practice. At that level, we are currently launching a project called Mom Care, Maternal Opioid Use Disorder Care and Resources in Custody, that is designed to help jail staff provide compassionate, evidence-based, non-stigmatized treatment that's specifically tailored to pregnant individuals and postpartum individuals in jail. So we're creating this resource and about to pilot it with a handful of jails across the country. We want them to provide the standard of care. We recognize that that's challenging, that every jail has a different environment, and not every jail is going to be able to get to that. But we hope at least at a minimum that they will provide at least one to initiate, to continue postpartum and save lives. But I think a bigger picture of this is as we work towards ensuring quality standard of care in jails and doing so in a way that is realistic for jails, we also need to think about what we're doing as a society, incarcerating pregnant individuals with opioid use disorder and pregnant individuals in general, and also incarcerating people with substance use disorders as the main form of management. Although we absolutely believe that jails must provide access to treatment, jails are still jails. And as a society, we need to invest more in treatment, and our courts need to consider that as well. Our policing, every aspect of the criminal legal system needs to rethink how it approaches addiction.
Well, this research illuminates a lot of different kind of converging points with these conversations. So thank you so much. This has been a great conversation. We appreciate your time. Camille Kramer and Carolyn Sufferin, thanks for being on Public Health on Call.
Thank you for having us.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Grace Ceciri. Audio production by J.B. Arbogast, Holly Cardinale, Spencer Greer, Matthew Martin, and Philip Porter, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Cesiri and Eliza Rosen. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.